name is Marissa Testa, and I am a dietitian within the complex healthcare program at Nationwide Children's Hospital. And today I'll be presenting on nutrition assessment in children with complex medical needs. The only disclaimer that I have is that I have 3 children under 5, and they could possibly make a guest appearance at any time today, as one already has. Objectives. So today, what I'm going to guide you through is the things we look for in performing a general nutrition assessment, things that you can do with your eyes, the simplest of assessments that you might be able to do. Understand how different types of disabilities affect nutrition status, identify nutritional concerns that patients with complex medical needs most often have, and understand just basic malnutrition.
Marissa, I'm sorry, let me interrupt. I don't know if your slides are showing.
Oh, let's see here.
Kara, do you see them?
I don't, but I wasn't sure if she was going to do that after the introduction. So
Okay.
I was waiting a
Oh,
moment.
there we go. How's this?
There. I think that's it. Yes, thank you.
All right,
Perfect.
I'm so sorry. Here we go.
No worries.
All right. So for a general nutrition assessment, things that we'll look for, or that I will look for as a dietitian, and that I encourage my providers or anyone that's interacting with children to look at, is to look at the history of a child, which can include their medical or surgical needs or history, psychosocial needs, as well as their diet history and any GI symptoms that they're having. Your physical observations, so things that you'll look at and that you'll see in your patients or in your students, or in individuals that you're interacting with or servicing, looking for like muscle wasting. Do they look really puffy? Are they alert? Are they lethargic? And then things that you can't see, like the biochemical studies or labs that they might get. Let's see. I'm having trouble moving forward now that I've shared. Okay, so as I mentioned, one of the most important things that you can do when you are caring for a patient is to just really look at them, to observe your student, to observe, your individual that you're caring for. So many things, like if you look at somebody most oftentimes and they don't look good, they're probably not. And sometimes we overlook that, especially with children with special health care needs, that like, well, maybe it's their condition. But one thing that I'll always tell parents, or I'll always, encourage providers when there's a little bit of a doubt, is there's no adult babies out there. Like every child should have the opportunity to grow. There's, in very rare cases, and I've experienced some of them, but every child should be able to grow. And so if you're seeing a kid that isn't growing, that's a sign that there could be some other problems that maybe that child is having. And so, reaching out and using some of these tools that I will go through can be really helpful to you. So assessing growth, what I will do as a dietitian, as I look at the growth charts, I see how a child is trending. We use the WHO growth charts, the World Health Organization growth charts for birth to the WHO's for under 2 is how I will help people remember. And if you're not familiar with them, they can look a little tricky, but I always go through this with patients and with parents, just because, especially with the new documentation in healthcare now, we have to be very transparent in helping parents and helping children, if they're cognitive, to understand, where they are on the growth chart is really important. So for kids that are 2 to 20 years of age, we'll use the CDC growth charts. And we also have disease-specific growth charts, for example, within cerebral palsy. So in cerebral palsy or in kids that have other complex medical needs, one of the main markers or the main clues for how a child is growing is their weight. This can be pretty challenging to get in kids that have a lot of equipment, which sometimes we'll subtract the patient weight from the wheelchair and the patient altogether, the parent holding the child, or if the child's able to stand, a standing weight. If you've worked with children with special health care needs, getting a length on them is exceptionally challenging. And there's a variety of tools that are used for that. As I go through my slides, these are 3 different measurements on the same child using 3 different ways. And you can see the variation. So this is a growth chart for a kid with cerebral palsy. He's a little boy and he's a GMFCS level 4. And I'll go through what a GMFCS level is here in just a moment. But this is just an illustration of it's the same child, it's 3 different types of measurements, and there's a lot of variability. So what I kind of encourage is draw a line through the data points. And these can vary by who's doing these measurements. I take them each with a grain of salt as I assess a patient, and really, draw a line through all those data points. I'm looking for the average, and I try not to overreact to any given weight or length. Let's double check it, let's verify, and let's see what the child actually looks like. So GMFCS levels is intended for patients with cerebral palsy, and it's their gross motor function classification system. And it helps us identify patient. There's a different growth chart for each level of ability for a patient. It kind of gives us an idea to compare little apples with little apples. Children that are at a level 1, that you can see the little boy carrying the box up the stairs, he's going to have more muscle tone. He's going to grow a little bit differently than a child that's a level 5 at the bottom of the screen that needs help holding his head up. He's going to grow a little bit different. And whether or not the child has cerebral palsy or not, I do like to use these growth charts with kids that have other types of disorders, just to help. Sometimes parents feel really discouraged that their kid has never been on a growth chart. And sometimes this gives the child the opportunity, or at least the parents the opportunity, to visualize their child on a growth chart. So you can kind of see the differences in growth. This is the same kid, just 2 different growth charts. So it's adjusted, it's their weight adjusted for cerebral palsy. And this is on the screen to the left. This is the unadjusted weight. And if we do adjust for, this would be a CP level 5, somebody that's non-ambulatory in a wheelchair, body mass distribution, muscle mass, fat mass is very different. As we go through patient history, the medical and surgical factors are important. So if a patient's had a Nissen, it's where the top of their stomach kind of is wrapped around their stomach to kind of strengthen that sphincter that's at the top of your stomach that keeps your stomach contents from regurgitating. But that can also make your stomach smaller, just like in bariatric surgery. So you might have a child that gags a little bit more if they're feeling some discomfort, as well as the type of feeding tube they have, video swallow studies, aspiration. All of these things can affect a child, as well as orthopedic procedures. So if a child has severe scoliosis and they've gotten a rod, that rod weighs something. Suddenly they're longer because they've been stretched out. So there's some other things to consider in your patients, as well as their comfort too, and how willing they might be able to learn just based on their world that they're in. Psychosocial history is really important for these kids. So our kids with special healthcare needs are twice as likely to be victims of abuse or neglect. It's often underreported because they can't speak up for themselves. And so that's really what we're here for. We're here to, you need help? Okay. We're really here to help those kids and to be their voice. And if you have if you have a reasonable doubt that a child isn't being fed, for example, in my profession, it's okay to speak up, because that child might not be able to speak up for themselves. Food security is also an issue that we're seeing, especially with COVID, as families have lost jobs or are afraid to go to WIC or to food banks, or as food banks are struggling with resources. So it's just something to be aware of with your patients or your students. Again, diet history, how well a child's able to eat or drink can affect their nutrition status, as well as constipation. I like to describe constipation as a freeway. If you have a big accident at the end on a freeway, you keep trying to shove more food or more cars onto that freeway, eventually all of that food that's backed up has to go someplace. And sometimes you can see some puking or increased reflux if there's a big poop ball that's blocking the free flowing of the GI tract. Diet assessment for kids under a year, the type of formula that they're taking, as well as how often they're taking it, can be really important to their growth, as well as different foods or liquid that are offered. Culturally, this can be really variable, where people of different cultures have different beliefs of when you start solids with a child, what's healthy for a child, what a healthy appearance is. how they feed their kids. Some cultures, it's totally normal to chew up their food first and to, regurgitate it into their child's mouth. And so just being sensitive to those different types of feeding, it doesn't necessarily mean that it's wrong. It just means that it is something different. And I try to be, as weird as some of those examples I gave sound, I try to be as open and as inclusive, and really try to make my nutrition plan fit with the family. For school and toddler age children, I'll often do a 24-hour recall. It's, pretty hard for families. What did you eat last night is the hardest question I ask families most of the time. And it's tricky. As well as the mealtime environment and routine. A child's ability to chew and swallow is really important. So if you're in the school setting, exercise that I encourage you to try is tilt your head back, open your mouth without closing your lips, and try to take a drink of water, again, without closing your lips. It's very, very difficult to do. And if you think of a child that has, they're super, they have high tone and their neck is like this, and you're trying to feed them with their head tilted back, it's hard. It's really hard. And it's hard for somebody that has normal muscle tone, much less your tone is different. And so just being really sensitive to, like, what is it like to be fed? What is it like for that child to be fed? And if you're one of the people doing the feeding, to be in tune to that child that you're feeding and you're interacting with. Some children respond better to different caregivers, and it's important to be aware of that, or that child just might not have a person that's patient enough to feed them. So I was just at the Aspen conference, and I just found that a very interesting illustration. Like, man, what would it be like for somebody to feed me? Most of us haven't had that experience. But to just take a glimpse of the kids that we might interact with, a glimpse into their world, it's an interesting thing to think about. Common issues that you might encounter with patients with complex needs. Again, the feeding intolerance, gagging, retching, vomiting, abdominal distension. Constipation is probably the number one thing I see, and it causes all of the above pretty much. We always have poop problems. It's the root of all the issues. We also have volume sensitivity, which we'll manage with tube feeding. And there's a lot of different types of formula that we'll use as well. And again, reaching out to a local dietitian through BCMH or some of your other community programs is the best way to go to find the most or the best way for patients to get exactly what they need in that area. There's many formula options. Standard infant formula is for babies that are under 12 months of age. I also tell families, like, nothing magical helps at 12 months to where a patient should have formula or shouldn't. It's what we recommend. It's what our policies recommend from WIC and different places like that, but there's nothing magical that happens from 11 months, 30 days to 12 months. And so if a child's on formula for a little bit longer or a little bit less and is switched to a different formula or cow's milk a little bit early, again, it's nothing that is, I get too excited about. As for the malnutrition component, I know, honey, but it's broken. As for malnutrition and cerebral palsy, and for kids that have complex medical needs, 40% of kids in this Flemish study that had a GMFCS, or I'm sorry, underweight was detected in almost 3/4 of patients with cerebral palsy that were more severely disabled. So a GMFCS level 5 in a wheelchair needing full assistance. But in this Flemish study, almost 40% of children that were greater than a GMFCS level 2, so maybe they needed help going up the stairs to the most severely disabled child with some dysphagia or swallowing difficulty, almost 40% of them were malnourished. So chances are that most of your patients that have some sort of, swallowing dysphagia, feeding difficulty, they're going to be at high risk for malnutrition. And it's really easy to miss these patients. Our clinic at Nationwide Children's and Complex Care is growing rapidly. And a lot of what we do, we're up to 4 dietitians that help manage all of our patients because malnutrition is such a prominent issue that we see along with feeding difficulties that we see in this population. There's a lot of indicators for pediatric malnutrition. We use the Z-score, so where a child is on the growth chart and how they are trending is really important. I won't go through these are a lot of numbers, but for your reference, and I'm also happy to take more questions into these. I realize I have a lot of slides here, but I feel like they're important. Again, these are indicators of pediatric malnutrition. So for kids greater than 2, these are the standards from the American Academy of Dietetics. The causes of malnutrition are variable. So there's organic causes such as malabsorption, allergies, mechanical feeding difficulties, and then there's inorganic reasons for malnutrition. So poor social situations and lack of access to food. Stressed families, we've been seeing a lot of that with COVID. So now what? You've identified malnutrition, you see a kid and you're like, I'm alarmed. This child doesn't look healthy. It looks like something's a little bit amiss. What can you do? You can reach out to the child's pediatrician. Nationwide Children's does have an outpatient clinic where they can get a nutrition assessment. Or if the child is disabled and does need to has some medical complexities, our complex care clinic is available as well, and families can self-refer. We try to make interventions that are practical for families. So oral supplements and preferred flavors, playing with the volumes, how much a child needs to take, simplifying instruction, drawing pictures, doing it with the family, and then addressing barriers. So sometimes, especially if you're in the schools, in a school system, for example, having enough time to eat. I used to work as a school resource coordinator in Whitehall City Schools, and I know what lunchtime's like in a schoolroom, school cafeteria, and it's crazy for kids to eat that can eat normally and open their own packaging. But if parents are sending foods that a kid that has special needs can't open themselves, or they can't feed themselves well, or they're not efficient at eating or chewing, all things to consider that, some of the barrier with weight loss could be in the school where they just don't have enough time to eat. And then as well as additional access to resources. And then how do I help families understand not only that nutrition is important, but their child does need to grow, because there's a lot of people out there that don't understand the importance of nutrition. And I'll kind of go touch on that a little bit more here in a second too, in this slide. So when I'm making my new nutrition interventions, and I think this is probably the most important slide for anyone that's working with a variety of people in a variety of situations, is to remember this hierarchy of needs. I think that, it's something that individuals in my profession as dietitians that we miss a lot, where I'm making recommendations for people that might not have like the base layers laid for their psychological needs. They might not have access to food, water. They might not have a home. They might not have their own home, and they're sharing their home. And then I'm asking them to do, pretty complex things that fulfill their child, but they don't have their own needs met as parents. And so I really tried to touch on like, how is the parent doing? Are they physically, mentally, are they able to do these things? Are they literate? Do they have the ability, have they had their needs met enough to meet the needs of another person? And what barriers can I take down to make them successful? So I try to make SMART goals. I try to, ask the questions and read the nonverbal cues in a family. If somebody's not making eye contact with me, they're short, they're angry, they're happy, they're bubbly. There can be a lot of reading between the lines that we need to do in meeting a child's needs. Because in adult care, it's the individual usually that you're dealing with. But when you have kids, like the kids have parents, and the kids don't get what they need without their parents. And so really trying to address the parents can really impact a child. And that's something that I really try to, and it's also it's stressful to be a parent, much less to be a parent with a child with special healthcare needs. In this time that we're in, we've had a lot of, patient deaths where patients haven't gotten the care that they've needed. and it's been a trying time. So I've kind of reshifted my focus in my counseling as, targeted at the parents and helping them making them successful, and trying to build them up in a time when, it's not only hard to be a parent, it's hard to be a teacher, it's hard to be everything. And so how can I make it a little bit easier on people, and working on my communication has been one of those things that I hope's made a difference. So I think this is probably one of the most important slides in your as you look and interact with patients. So yeah, but in summary, these are just some of the things that hopefully we went through, that I hopefully remembered to go through everything. So just the growth, the variability. I didn't really touch on this a lot, but kids with different gross motor abilities have different calorie needs. Malnutrition is prevalent, and the best assessment is to use your eyes. And if a child doesn't look well, they probably aren't. So feel to reach out to their primary care doctor, or to reach out. I'm always happy to help direct if there is a kid or a question that you do have in the future. And there are my references. Yeah, thank you so much for having me.